So today I'm going to talk about acute coronary syndrome, and we must be clear regarding the terms. So what are the symptoms of acute coronary syndrome? One is the chest pain, the sweating, nausea, vomiting or diarrhea. So that coming toward the chest pain, we know that the cause for the chest pain is ischemia. The cause for the chest pain is ischemia. There is decreased blood flow, there is decreased oxygen. When there is decreased oxygen, there is ischemia. There is production of lactic acids and all these things which stimulate the nerve ending and causing pain. Now we must be clear what is typical chest pain, what is atypical chest pain, and what is non-cardiac chest pain. So these are the three things. Central, if the pain is the central, 1 point. Increases with exertion or excitement. Second, this has also got 1 point. 1 point, this has got 1 point, and this has also got 1 point. So we are having 3 scoring, and relieved with rest or nitrates. Pain is central, pain increases with exertion, and relieved with rest or nitrates. If all the 3 are present, 3 by 3, this is typical chest pain. If 2 by 3 is present, this is atypical chest pain. If 1 by 3 is present, this is non-cardiac. This is non-cardiac. In some patients, such as diabetic or autonomic neuropathy patients, there is no pain. This must be kept in mind. So they usually present with sweating or nausea, vomiting and diarrhea, or they present with shock, cardiogenic shock. Why there is sweating? Because when there is a decreased oxygen coming toward the heart, to the heart muscle, there is activation of sympathetic system. The sympathetic system activation causes sweating. So that is the reason for that. And cause for the nausea, vomiting or diarrhea is the vagal nerve stimulation, and that is usually seen in the inferior wall MI. Patient present with the nausea, vomiting or diarrhea. So these are actually the symptoms, this portion. Now coming toward the classification of the acute coronary syndrome. The ST elevated ACS and the non-ST elevated ACS, that is acute coronary syndrome. So the non-ST elevated ACS is further divided into 2 things: the non-ST elevated MI and the unstable angina. Now this is MI because the enzymes are raised in this. In unstable angina, the cardiac enzymes are normal. So a patient comes to you with acute coronary syndrome and you did ECG. That ECG shows ST elevation. Now if the presentation of the patient is early, that is less than 6 hours or less than 12 hours, you can say if the presentation of the patient is less than 12 hours, then thrombolytics or angioplasty has got a role, which decreases mortality later on. And if it is more than 12 hours, then thrombolytics has got a very little role. Why thrombolytics have got a role in ST elevated MI and non-ST elevated MI? To understand this, we have to look at the vessel level. Let's suppose this is coronary artery in this patient, and this is coronary artery in this patient. In this patient we are having complete cut off blood flow. The blood flow is completely cut off, while in this patient there is some little flow. Point number 1. Point number 2, in this patient there is thrombin. This is thrombin rich. This clot is thrombin rich. This clot is platelet rich. In this case, yet the fibrinogen is not converted into fibrin and they have not formed that mesh or network. While in this case there is thrombin formation, but yet there is no organization. No organization means the fibrin, when it is formed, then they form further network, then they form another network, so they form a thick lacy pattern. When their thick lacy pattern is formed, we say this is organized. We say this is organized. So when there is no organization, thrombolytics can dissolve this clot. Thrombolytic can dissolve this clot, and that is the reason for less than 12 hours we are having maximum benefit, because there is no organization. If there is no organization, the thrombolytics can dissolve this clot. Once the 12 to 24 hours have been reached, the thrombolytics have got no role to dissolve this clot, because there is a thick network formation, and this is called organization of the clot. And this is called organization of the clot. So that is the reason. And if you give thrombolytics over there is no thrombin formation till now. So if you give thrombolytics, do you think the thrombolytics can dissolve this platelet rich clot? No. That is the reason the thrombolytics cannot work in this patient, while it can work in this patient. Point number one. Point number two, why it can work only for 12 to 20? Why it can work for only 12 hours or 12 to 24 hours? The reason is organization. After 12 to 24 hours, there is organization. And once there is organization, it cannot dissolve this clot. What is meant by ACS protocol? When you suspect ACS, if this is the ST elevated or non-ST elevated, in both of these patients, when you suspect acute coronary syndrome, in both you give these drugs. Tablet aspirin 300 milligram state, tablet clopidogrel 300 milligram state. Now the one tablet of aspirin that is actually 300 milligram, the strength is usually not written above that tablet, but that is 300 milligram. So one tablet you can give the patient and ask him or her to chew. But if you are having Loprin 75 milligram tablet, you have to give 4 tablets. Similarly, clopidogrel come in the strength of 75, so you have to give 4 tablets. The third one, the statin. Give the tablet rosuvastatin 20 milligram state. Rosuvastatin gave 20 milligram state. Fourth one is injection heparin or clexane. Now this has got a role in non-ST elevated MI. You do an ECG. If the ECG has got no ST elevation, so you give injection heparin or clexane, because the blood vessel is not completely occluded and there is still blood coming out. So if you give heparin, there is only platelet over here. There is only platelet. So if there are only platelet, you stopped the progression of platelet toward the thrombin rich clot. So you have actually prevented that clot propagation, and you have actually prevented that organization. So this is actually the best drug in case of non-ST elevated MI. If you are having ST elevated MI, then stent, thrombolytics or stenting, these are the answer. Now if the patient lives in such a facility where the stenting is possible, so the answer is stenting. If the patient lives in such facility in which there is no facilitation of stenting, you give thrombolytics. That is, give SK or tissue plasminogen activator, and you look for the resolution of ST segment elevation after you have given the injection. But this is actually the ACS protocol, and you can give in all patients in which you suspect the ACS. You give aspirin, you give clopidogrel, you give rosuvastatin, and you give heparin or clexane. You can also give the NG-set tablet, but that is only for pain. If the BP is low, don't give nitrates. If the BP is low, don't give nitrates. How would you differentiate between the NSTEMI and unstable angina? The answer is cardiac enzymes. If the cardiac enzymes are elevated, this is NSTEMI. If the cardiac enzymes are normal, this is unstable angina. So if a patient is having this setup, what is the best next step? Do TIMI scoring, TIMI scoring. There is calculator available for that. If that shows high risk, do angiography. Do angiography. If that shows low risk, then the answer is monitor only. Monitor and medical management. Monitor and medical management, and then follow up. Monitor and medical management, and then follow up. So this was a short scenario, short concept regarding acute coronary syndrome. So you are having ST elevation and non-ST elevation, we discussed in detail, and the TIMI scoring. That is thrombolysis, thrombolysis in MI, but which MI? The non-deteriorated MI and the unstable angina. That scoring is available on the net, direct on the Google or in a Medscape. So that will label high risk or low risk. If the score is 5 to 7, that is high risk. 3 or less than 3, that is low risk. 3 to 5, that is intermediate risk. So if high risk, angiography is the answer. If low risk, then monitor and medically treat the patient and need follow-up.